Okay, this next part, we're going to talk about more advanced disease and treatments. And so we've been doing a number of these treatments. It's been a pretty exciting time. And really, we've learned a ton over these last several years with these new treatments. So I wanted to kind of start thinking about what we're doing. And so evolving thoughts with using these treatments and really moving forward with trying to hope we have a treatment and fantastic outcomes for really everybody. So I'm going to talk about a little bit of the current treatment landscape and some issues of that, of when to treat, when to stop, who do we treat. Again, working with all of these new agents. It can be a little bit overwhelming. So the first FDA approval for advanced melanoma, so stage 4 melanoma, as you know, is spread. So metastatic melanoma. So in 1970, DTIC, or dacarbazine, was a chemotherapy. And it was really approved because nothing else had any activity. And unfortunately, that was the case for decades until high-dose IL-2 came along. And so this is a new type of therapy. This is quite unique. And now it's becoming a little bit of an old hat. But this is the first time we really showed what the power of immune therapy, which is long-term control. But it just didn't work that well. And unfortunately, it took another decade plus to really find something that had some benefit. This is the ipilimumab, or Yervoy, is the first thing that we've shown in a trial actually have people living longer. And then it was a little bit of a windfall. So there's a BRAF inhibitors now that came out, different combinations of those. The PD-1 inhibitors, pembrolizumab and nivolumab, or Opdivo and Keytruda. There's cobimetinib, which is in combination with vemurafenib. There's a unique type of therapy which is injected into a lesion, or T-VEC. It's kind of modified herpes virus. And then the combination of two of these together, of ipilimumab and nivolumab. And hopefully, the train doesn't stop. We have a number of other therapies that we're testing, as well as trying to optimize how we use these. And I think that's some of the things we're starting to think about kind of moving forward here and do today. So just a few examples. So ipilimumab, this is a kind of representative picture, but this is a patient who was treated. This is a PET scan, just kind of a scan of the whole body. And all of these little black spots are melanoma. But after treatment, you can see it's almost completely resolved. And ipilimumab, we really have data now out past 10 years. And it appears about 20% of people will be living and doing well, maybe with no disease, beyond 10 years. And we hope that is ongoing. IL-2, when we did it, was really about 5%. So it really was a marked improvement, but still a long way to go. So this is an example of a BRAF inhibitor, vemurafenib. This is a cross-section of the chest, a CT scan. So all of this right here is disease and collapsed lung. And with treatment in a relatively short period of time, you see a pretty remarkable response. The problem with some of these BRAF inhibitors, it's very, very active. It's predicted to have some kind of shrinkage, but they tend not to work, especially for cancers like this and melanomas like this that tend to be fairly aggressive. So again, trying to think about where would these come into play and what are we doing with them. This is a patient who's a decent amount of disease on the chest. That's all melanoma. And this patient got pembrolizumab, and you can see these kind of flattening out. And actually, over time, I don't have a picture of the one in January 16, it really had all flattened out. It was no disease, really. We call it tattooing or melanosis. We biopsy then, there's no active disease. This patient also had some disease in the lung, also had disappeared. Pembrolizumab and nivolumab, we don't have great long-term data yet, just because they're newer. But it appears about 30 to 40% of patients will be living years. And we kind of hesitate to say cure, but we hope that that's the case. One big problem in melanoma is the brain. Historically, it's been a problem. It turns out that a lot of these treatments have activity in the brain. And with these immune therapies with long-term control, we're starting to see that kind of play out as far as complete control in the brain and long-term. This is a cross-section of the brain. These little white spots are all melanoma. And again, in a relatively short period of time, you can see those disappear. I don't think it's hyperbole and overstate the importance of this. I mean, historically, even IL-2, you could see disappear in the body, and all of a sudden it shows up in the brain, and people die from that. And we're starting to see this really make a difference for people. I wanted to illustrate some of the thoughts about what we're evolving thoughts with these new treatments and how we're using these with a case. The 53-year-old man who had a melanoma in January of 2002 on his low back, had surgery, of course, and many, many years later actually had a recurrence of that melanoma. The same melanoma had come back. Had surgery for that. But in a relatively short period of time, so he probably had disease already had spread, his PET scan actually showed a pretty substantial amount of disease in the chest. This is actually inside the body. This is not on the skin. I can't rotate this, but and symptomatic, wheezing, pain from all of that disease in July of 15. So this was around the time when we had finished a trial of this combination therapy compared to actually single agents each, and it looked promising. And so it looked like it was heading to the FDA for approval. And we were able to get what's called an expanded access trial, or allow it to be given to patients while we were waiting approval. So this is quite fortunate. And fast forward, all of this disease appeared to have disappeared. And what we love to see on reports and tell people, there was no evidence of disease, or NED, or NED, I guess you could call it. Our friend. Actually, I have this kind of ongoing joke with patients that eventually I'm going to have a dog, and his name will be Ned. So, TH, aka Ned. So we decided to stop treatment, no disease. All these been tolerating it pretty well. Had some side effects. We decided to stop. Actually, in September 2017, we still see no evidence of disease. And I know this for a fact today that he has no disease, because he's actually in the back. TH, if you want to stand up and be acknowledged. You may not recognize him without his skin on. And continuing to do well. But let's go back in time a little bit. Of course, it's fantastic, And actually, I could have had, multiple examples, even in this room, of patients doing very well. But there's still things that we need to work on and figure out. Even if, let's say it didn't respond like that. Well, maybe we could have done something different, would eventually respond, including, why didn't we do this when it first shows up, instead of having to wait till it spread? Is it worse if you wait? Is it, again, maybe got lucky if you saw that. But there may be some science behind why it might even be better. But what about when it spreads the first time? The surgeons are talking about it spreading to the lymph nodes. There's definitely a chance of being cured with that. But there's also a chance, depending on some details, that there's still disease somewhere. There's microscopic cells somewhere. And again, very difficult to predict that. But what if these therapies could work early on? Why don't we treat it when it first occurred? Of course, this is historical. In 2002, we really just didn't have anything. But nowadays, we're readdressing that and rethinking our thoughts. There's a little complicated slide. My daughter said it was a little too complicated, but I couldn't figure out how to edit it anymore. So this is so the concept is you're first diagnosed, right? So you have a melanoma on the skin, you take it off. Early stage disease is highly curable. So my point is that this is where we would consider these what we think is fantastic treatments for a lot of people. Should we do therapy at that time? Well, if you're cured from surgery, which is still early detection, prevention, and surgery, it cures way more people than we would do, have more impact overall, really. So it's really this kind of team approach still. But should we do additional surgery? Again, if his benefit is relatively small, there's a lot of issues with that. Should we do it? But once it's kind of spread into a lymph node, and this is where some of that discussion, if you've heard of adjuvant therapy, so many of you may have had that discussion. Again, should you have additional therapy after surgery? Should we be doing these treatments then? Or what if it comes back? And should you do surgery? All of these areas right here actually are predominantly managed surgically. We take it out. We take it out with a chance of being cured. But you can see as it goes, or you can imagine if it goes along, that the risk goes up that there's still something there. And so if you take it out when it actually spreads like that, it's almost a guarantee that there's still some cell somewhere. But when you take it out, you can't see anything. You don't know. And then you're playing this risk game. So you're treating a risk and a possibility and the perceived benefit of that treatment when you really don't know when you take it out. Stage 4 is a little different when it's spread. obviously you see something that is life-threatening, and so of course we do therapies and offer those therapies at that time. But again, just some thoughts. Again, this term adjuvant, essentially after surgery in our world. And so we take some of these factors into play. So what is the risk of recurrence? If it's really small, again, some people have mentioned ulcerations and mitotic. This is just kind of under the microscope what that looks like. That bumps your risk up because it tends to be a little more aggressive. But what it was just this small area, didn't have those features, the risk is you're very likely to be cured. But we take that into account. But as well as the specific treatments. Okay, so I tell you all of these things of exciting new treatments, but the reality is for adjuvant therapy, it's still limited. So we don't have those yet. We're studying them. And there's a little bit of new data that I'll just mention. but as well as side effects. I mean, if I told you could take an aspirin and you'd be cured, I mean, 100% of people should take that. Well, if you could tell it, 100% of people at least have the potential to be able to take it, versus some of these treatments which are pretty toxic. You have to balance that stuff out. So again, balancing out with the benefit. And this is a key point. It's actually was brought up in the surgical talks. Is there a risk of waiting? So is it really worse if you were to just be watched? And if it recurs, people said it doesn't change, quote-unquote, survival. Like, you don't necessarily die from that. Well, why is that? And is it something where we actually could just wait? You avoid some of the complications of surgery, or maybe even doing some of these treatments that might be quite risky, have a problem, a complication, when you don't even know if there's melanoma there. Well, what if you waited? If you waited and it showed up, would you do just as well? And there's some thoughts that, in my mind, I think there's a possibility that you could do better or have a better chance of responding. So I'm trying to separate out this kind of concept of stage 4 or stage 3 melanoma. So stage 4, again, is metastatic melanoma. It has spread, into the body somewhere else. And then stage 3. Stage 3 is typically into a lymph node, and you remove it. You don't know if you have disease. There's a chance you're cured. Again, stage 4, you see it. It's life-threatening. We've got to do something about that. But stage 3 is a discussion, a lot more complicated. The other problem with stage 3 right now is that of all those therapies I mentioned that are FDA approved for melanoma, really only one of those is approved, and that's ipilimumab. And this is high-dose ipilimumab, which is quite toxic. There is interferon that's available. It's been around for decades now. It's come under some scrutiny just because of the unknown real benefit over time. There is new data, actually even with a couple of weeks it's been presented and published, that may change that. We've been voting on whether some of these new treatments will make it into our armamentarium of options for stage 3. But right now, that's it, or a clinical trial testing some of that. So I wanted to, I don't know how provocative this will be. I think this is a fascinating, actually, thought that I don't think a lot of people have been thinking about or talking about. Okay, so if you have a therapy and you take it out, you're potentially cured. But what if you said you have a 50% chance that it's still there? Well, what are you going to do about that? Well, in breast cancer, probably some of you know people who have had breast cancer or colon cancer. A lot of times that's chemotherapy. Chemotherapy are basically drugs that kill the cells, damage the DNA, and they kill the cells, as well as radiation. Conceptually, the way tumors grow, if it's small, you can treat that. If you treat that relatively intensely, it can knock those cells down, not let them grow back, and eventually potentially be cured, like they're gone. When they're larger, those are significantly less likely, because it's hard to get if you have a mass, it's hard to get that all the way down to nothing. There are certainly some people that do, but that's the concept. I think the BRAF and MEK, this is dabrafenib, vemurafenib treatments, may have the potential very similar to these agents, meaning that we think of BRAF inhibitors, for the most part, of being very, very active. I'm very surprised, actually, if I don't see a melanoma shrink when someone is a candidate and gets these treatments. But the problem is, again, if it's significant, like you saw that picture. I didn't show you the follow-up picture where it just closed right back within a few months. It tends to develop resistance. But and we think of immune therapy as long-term control and BRAF not. But if you look at the data for melanomas, metastatic melanomas that is relatively small, like you have a few lesions or less than 3 areas involved, those patients actually have a substantially higher chance of long-term control with those therapies. If you take that to the extreme, adjuvant therapy where there's microscopic disease, I think there's a good chance that actually could work very well and potentially be curative if we use it in that scenario. These are therapies that are now, again, a couple of weeks ago was published with some preliminary data. That has to play out and we'll see. But in my mind, it makes a lot of sense, especially if we're thinking we do this more advanced disease, we see it shrink, we all feel good about that, but what we care about is long-term control. We want to see it gone and people living their normal lives. I think immunotherapy is different. And this is still, again, to be kind of played out. But immunotherapy, it's complex. So one of the arms of immunotherapy, your immune system, you have to identify the cancer, identify the melanoma. And then it has to activate the system to try to get rid of that, right? So if you have microscopic disease, very, very small, it's very possible that your immune system kind of scans right over. It doesn't do anything for it, right? But if it's bigger, it has a potential to see it. There's just more of it. As well as we know that when melanoma and cancers in general, when they grow and spread, they become more abnormal. They develop mutations. And this has been, again, demonstrated a lot with you may have heard these mutational load. Like you get more mutations and abnormalities. And turns out the higher or more abnormal it is, the more likely it is that the immune therapy will work. The melanoma in particular has one of the highest mutational burdens. It's the most abnormal. But when it's small, you can't see it. But if it is allowed to grow a little bit, again, an odd concept, if you see it kind of grow, it's possible that the immune therapy might work better. The other thing, again, with these particular therapies, it has to see it, but then you have to have something else kind of activate that. And that's where these other therapies might come into play, where it allows it, because the cancers can also block the immune system, but these new therapies can come in and actually work. So just as a concept, when we're thinking about when should we initiate these therapies and when should we do surgery, and then. But I think certainly, and now in our multidisciplinary clinic, we're talking about this more regularly. Meaning, should we do a treatment like this before we do surgery? Number one, if you take it out and do a treatment, you don't know if it's working. You have no idea. You just follow people. How long do you treat? We don't know. But if you see it shrink, you know if something is working, and you know if you should push that. It's a possibility to avoid surgery. It's also a possibility that just if you see it, but you still do surgery to do anything possible to clear it out, you may actually be able to continue that therapy, and you could do well long term. So in my mind, this concept of immune therapy, I think, plays in two ways. Maybe before surgery, before you take it out completely, and of course, in the more advanced setting. But I think in this kind of adjuvant post-surgery world, I'm not so convinced that immunotherapy is the best way, but there's certainly data that suggests it could still be beneficial. But maybe if we're able to pick and choose, maybe the patients who are at the highest risk are the ones that really would benefit from that. And again, there's a lot of little detail to this and certainly complex biology. But I think also that this makes a lot of sense to me, that this is a therapy that we would do. If you have a BRAF mutation, you have to have this abnormality within the melanoma, that this is something that might be kind of pushed and people could do very, very well. So again, just kind of, I don't know how this will play out around the world and what people are thinking, but to me, this makes a lot of sense, and I think it's certainly pretty exciting as we're having more options kind of moving forward, and as well as the toxicities of some of these treatments. They said, oh, this is bad. Let's give some of these immune therapies, as Dr. Fescher talked about, can be quite toxic, and we got to be super careful with that. So what about this concept of stopping? So let's go back a little bit. So TH had, pretty substantial response, and appeared to be the disease disappeared. And he's also tolerated it. I mean, maybe had little thyroid problems, but otherwise had been doing well. Well, why would you stop? I mean, tolerating it, it's working, you keep going, right? Well, this is something that we're starting to learn over time, that if it does disappear, the chances actually of it coming back are fairly low. But some of these ideas is like, well, if we stop now and if it comes back, then what are we going to do? Can you just come back? And so these are the questions, obviously, when we're thinking about that. But one of the things we do know with immune therapy is this long-term control. And again, we're all hesitant to say cure, but I'm going to say I think there's a very distinct possibility that some of the people in the room, as well as watching, that you're cured from your melanoma. Now, again, we've watched that. We don't ignore that. We have to be monitored. But I think that's the potential benefit of immune therapy. Even if you train your immune system to be able to protect you, that's what it does. And maybe 15 years from now, if it comes back, then maybe you could do something. But I can guarantee you, our therapies will also be better in 15 years. But there is this unknown effect over time, if you're treated for an extended period of time, of what toxicities you'll get. We know that they're fairly toxic for some people early, but what are we doing to people over an extended period of time? We really don't know. And so in the trials, we would just go forever. And again, now that we have these therapies for a number of years, we're able to watch people, and we say the likelihood of a recurrence is exceptionally low. So what is that chance? Well, if you have a complete response, or NED, it's exceptionally rare. There isn't a lot of published data for that. It's certainly our own experience. But there is a chance, unfortunately, and this is JR, a 44-year-old had melanoma on an abdomen in 14, had it surgically resected, unfortunately recurred fairly early. Because it was, we didn't seem to be getting rid of it, we tried high-dose IL-2 at the time, young person, healthy, this is our chance, kind of a home run. Doesn't work often, but if it works, it's gone. It didn't work. So we had to go to a surgical route because it still seemed to be fairly contained. and then did ipilimumab at the time. Unfortunately, this is the kind of report we don't want to see, which is interval progression of the disease. All the rest of this doesn't matter. It was actually progressing despite the ipilimumab in March of 15. Fortunately, we had a number of agents that we've been studying, and one of them was pembrolizumab, and actually was approved by then, and we were able to do that to follow immediately after ipilimumab. And fast forward, not that much time, actually, had a tremendous response and appeared the disease had disappeared completely. So fantastic. We watched over time. And so this is a good dilemma. It said, actually, once it's disappeared, should we stop? That's how it kind of came up. And said, wow, you responded so quickly that maybe it's gone, and then we can just stop. And then should we do that? This was at the time. This is a couple years ago, obviously. And so we're unknown. So 9 months of therapy, actually, at the time when we were trying to make the decision, there's no signs of disease, actually fairly early on. There were some side effects. Actually had, I think Dr. Fisher probably mentioned this kind of very rare or unusual type of this hypophysitis, which is a pituitary dysfunction, a kind of master hormone gland, but pretty severe joint pain, actually. Really severe bursitis was really kind of quite disabling. And so we just decided to stop on October 15, and we just kind of went on this surveillance mode, so routine exams and imaging. Unfortunately, in January of 17, on routine imaging, this is a cross-section of the brain, a mass showed up. Fortunately, there was nothing else in the body and nothing else in the brain. It was just this one spot and no symptoms. So we moved forward with taking it out. We were doing radiation to that surgical bed to try to eliminate any cells that might be left behind. And we decided to go back on the other PD-1 inhibitor of nivolumab, and we've continued. And quite impressively, probably the best MRI I've seen post-treatment of any type, where you hardly see anything. I mean, pretty remarkable. And rest of the body as well, no evidence of disease. This image anyway is from August 17. I also know that he's disease-free, and we had a lot of discussion. Actually, said, how long should we go? A lot of discussion because we talked about that. He's also sitting here today, right here, if you want to be acknowledged for that, doing fantastic. So I think, so some of that is, trying to bring up when we counsel people, say, look, this is very, very unlikely. The data does not suggest that it's going to come back. But if it comes back, we can do something about it. So this is my N of 1, knock on wood, that it recurred after what we believed, felt like this was a true, complete response. And right now, back to no evidence of disease based on some of these other therapies that we can do. So just to kind of wrap up, certainly exciting and hopeful times. Again, there's a lot of other factors involved here. We believe that a complete response really matters a lot. But there are people who have a partial response. Sometimes we've been removing residual disease, radiation, some kind of ablations to try to get them, hoping that if we can render people eventually disease-free, that would also result in long-term control. But even partial responses, stable disease, they seem to be maintained with immune therapy. And, if anyone's in that situation, don't be discouraged. I mean, those are things that if we can maintain that for an extended period of time, we may have other options. And we're working on new therapies. As we speak, there may actually be a new agent even approved within the next year or two. So these are good problems to have, these new agents, when to stop them. But we've still got a long way to go and a lot to learn, including how to manage that, which Dr. Fisher will get into. So stay tuned. That's it.